Hello everyone, and welcome to today's lecture on hypothyroidism. This is a condition that every medical and pharmacy professional should be well versed in due to its high prevalence and significant impact on patient health worldwide. Hypothyroidism results from insufficient production of thyroid hormones or impaired hormone action, which leads to a slowdown of metabolism affecting almost every organ system. We'll start by revisiting the anatomy and physiology of the thyroid gland to understand how it normally functions and how this balance is disrupted in disease. Then we'll move on to the clinical features that patients with hypothyroidism may present with, ranging from subtle to overt symptoms. After that, we will examine the different causes of hypothyroidism, from autoimmune destruction to iodine deficiency and central causes involving the pituitary or hypothalamus. Next, we will discuss how to make the diagnosis using laboratory tests, imaging, and clinical judgment. Treatment is the cornerstone of managing hypothyroidism, and we will cover the pharmacology of levothyroxine, monitoring strategies, and potential drug interactions. We will also touch on non-pharmacologic management strategies, special populations such as pregnant women and children, and potential complications if hypothyroidism is left untreated. By the end of this lecture, you should have a comprehensive understanding of hypothyroidism that will be invaluable in both clinical practice and pharmaceutical care. Let's outline what you will gain from this lecture. First, you will learn a detailed definition of hypothyroidism and understand its pathophysiological basis, why and how thyroid hormone deficiency develops, and the effects on the body. Second, you will be able to recognize the broad spectrum of clinical features, understanding why symptoms vary with severity and patient demographics. Third, we will discuss the diagnostic criteria, including interpreting thyroid function tests, especially TSH and free T4, and the role of thyroid autoantibodies and imaging. Fourth, you will learn the common and uncommon causes of hypothyroidism, including autoimmune thyroiditis, iodine deficiency/excess, drug-induced hypothyroidism, and central causes due to pituitary or hypothalamic dysfunction. Fifth, the lecture will delve deeply into management strategies, focusing on pharmacological treatment with levothyroxine, including initial dosing, dose titration, monitoring, and managing drug and dietary interactions. We will also discuss non-drug measures to optimize outcomes. Finally, you will understand the complications associated with untreated hypothyroidism and special considerations during pregnancy, pediatrics, and in patients on certain medications. This comprehensive approach ensures you are well prepared to diagnose, treat, and counsel patients effectively. To understand hypothyroidism, we must first understand how the thyroid gland normally works. The thyroid is a butterfly-shaped gland located in the lower anterior neck, weighing approximately 20 grams in adults. It consists of follicles lined by epithelial cells filled with colloid, where the precursor thyroglobulin protein is stored. Thyroid hormones T4, thyroxine, and T3, triiodothyronine, are synthesized here. Although T4 is produced in larger quantities, T3 is the more biologically active hormone. In peripheral tissues such as the liver and kidney, T4 is converted to T3 by deiodinase enzymes, allowing tight regulation of hormone activity. These hormones play critical roles in regulating basal metabolic rate by stimulating mitochondrial oxygen consumption, thermogenesis, and protein synthesis. They influence carbohydrate metabolism by promoting gluconeogenesis and glycogenolysis and affect lipid metabolism by enhancing lipolysis and cholesterol clearance. Beyond metabolism, thyroid hormones are crucial for normal brain development, particularly during fetal life and infancy, and influence cardiovascular function by increasing heart rate and contractility. The hypothalamic pituitary thyroid axis maintains homeostasis. The hypothalamus secretes thyrotrophin-releasing hormone, TRH, which stimulates the anterior pituitary to release thyroid-stimulating hormone, TSH. TSH then stimulates the thyroid gland to uptake iodine, synthesize thyroglobulin, and secrete T3 and T4. Negative feedback from circulating T3 and T4 inhibits TRH and TSH production, maintaining hormonal balance. Disruptions at any point in this axis can lead to hypothyroidism. Hypothyroidism is defined as a state of deficient thyroid hormone production or action leading to impaired metabolism and systemic effects. It can be categorized into primary hypothyroidism, where the thyroid gland itself is diseased, secondary hypothyroidism, due to pituitary gland failure resulting in low or absent TSH secretion, and tertiary hypothyroidism, caused by hypothalamic dysfunction leading to insufficient TRH release. Primary hypothyroidism accounts for the majority of cases. Worldwide, hypothyroidism affects about 1 to 2% of the population, with higher prevalence in women, especially over 60 years old. Risk factors include autoimmune disease, iodine deficiency, radiation exposure, and certain medications. The clinical manifestations range from subtle nonspecific symptoms like fatigue and weight gain to more severe signs such as myxedema and heart failure. Because thyroid hormones influence nearly all organ systems, patients may present to different specialties with varied symptoms, highlighting the importance of maintaining clinical suspicion. The impact on neurocognitive function, lipid metabolism, and cardiovascular health underscores why early diagnosis and management are crucial. The causes of hypothyroidism can be grouped into primary and secondary/tertiary origins. The most common cause of primary hypothyroidism in iodine-sufficient areas is Hashimoto's thyroiditis, an autoimmune disorder where lymphocytic infiltration destroys thyroid follicles. Patients often have circulating antithyroid peroxidase, anti-TPO, and antithyroglobulin antibodies, which can be detected serologically. Iodine deficiency remains the leading cause globally and results from insufficient dietary iodine, which impairs thyroid hormone synthesis and may lead to goiter formation. Iodine excess, for example from certain medications or supplements, can paradoxically inhibit hormone synthesis, Wolff-Chaikoff effect. Other causes include thyroidectomy or radioactive iodine therapy used in hyperthyroidism or thyroid cancer treatment. Congenital hypothyroidism arises from agenesis, dysgenesis, or enzymatic defects affecting hormone biosynthesis, necessitating early neonatal screening. Secondary hypothyroidism is due to pituitary failure from tumors, trauma, or infiltrative diseases reducing TSH secretion. Tertiary hypothyroidism arises from hypothalamic dysfunction affecting TRH secretion. Drugs such as amiodarone, lithium, interferons, and tyrosine kinase inhibitors can induce hypothyroidism by various mechanisms, including direct thyroid toxicity or altered hormone metabolism. Hypothyroidism results from reduced circulating thyroid hormones, leading to systemic effects due to impaired metabolic activity. In autoimmune hypothyroidism, cytotoxic T-cell-mediated destruction of thyroid follicles leads to decreased synthesis and secretion of T3 and T4. The hypothalamic pituitary axis responds by increasing TRH and TSH secretion in an attempt to stimulate the failing gland. However, the thyroid cannot respond adequately, resulting in elevated TSH and low thyroid hormone levels, a hallmark of primary hypothyroidism. This hormonal deficiency reduces oxygen consumption and metabolic rate in tissues, slowing cardiac output, causing cold intolerance, and decreasing gluconeogenesis. The accumulation of glycosaminoglycans, particularly hyaluronic acid, in the interstitial spaces leads to non-pitting edema called myxedema, prominent in skin and other tissues. Secondary and tertiary hypothyroidism present differently, with low or normal TSH levels despite low T3 and T4, because the defect lies in the pituitary or hypothalamus. The systemic manifestations of hypothyroidism reflect these biochemical changes, affecting cardiovascular, neurologic, gastrointestinal, and reproductive systems, and impairing lipid metabolism, leading to elevated LDL cholesterol and atherosclerosis risk. Patients with hypothyroidism may present with a spectrum of symptoms, often developing insidiously over months to years. Early symptoms include fatigue, weakness, cold intolerance due to impaired thermogenesis, constipation from decreased GI motility, dry skin caused by reduced sweating and sebum production, and hair thinning or loss. Weight gain occurs despite poor appetite because of decreased basal metabolic rate. Neuropsychiatric symptoms such as depression, slowed cognitive function, and poor concentration are common. Physical examination reveals bradycardia, delayed relaxation phase of deep tendon reflexes, a classic neurological sign, periorbital puffiness, and a hoarse voice due to vocal cord edema. Myxedema, characterized by non-pitting edema of the skin and subcutaneous tissues due to mucopolysaccharide deposition, imparts a characteristic dull facial expression. Goiter may be present in autoimmune thyroiditis. In severe or prolonged cases, myxedema coma may develop, marked by hypothermia, hypoventilation, hypotension, and altered consciousness, a medical emergency. In children, hypothyroidism leads to growth retardation, delayed bone age, and intellectual disability if untreated, known as cretinism. Diagnosis begins with thyroid function tests. The hallmark of primary hypothyroidism is elevated serum TSH and low free T4 levels. TSH measurement is highly sensitive and is often the initial screening test. In central hypothyroidism, secondary or tertiary, TSH levels are low or inappropriately normal despite low free T4, so both values must be interpreted together. Testing for thyroid autoantibodies, particularly anti-TPO antibodies, confirms autoimmune thyroiditis. Ultrasonography of the thyroid gland can reveal gland size, echogenicity, and nodularity to support diagnosis and exclude malignancy. Subclinical hypothyroidism, where TSH is elevated but free T4 remains normal, is common, especially in elderly women, and management depends on clinical context and comorbidities. Additional tests such as lipid profiles may reveal hypercholesterolemia. Anemia is common due to decreased erythropoiesis. In pregnancy, early diagnosis is critical to prevent fetal complications, and TSH targets are lower. Differentiation from other causes of fatigue and weight gain, such as depression, anemia, or chronic disease, is important through thorough clinical and laboratory evaluation. If hypothyroidism is not diagnosed and treated early, it can lead to serious complications. Myxedema coma, although rare, is a life-threatening emergency triggered by infections, cold exposure, or sedatives in severely hypothyroid patients. It presents with profound hypothermia, bradycardia, hypotension, hypoventilation, hyponatremia, and altered mental status progressing to coma. Cardiovascular complications include increased atherosclerosis risk due to hypercholesterolemia and decreased clearance of LDL cholesterol, pericardial effusion due to increased capillary permeability, and congestive heart failure due to reduced myocardial contractility and heart rate. Reproductive health is affected, with menstrual irregularities such as menorrhagia or amenorrhea, infertility, and increased risk of miscarriage or preterm birth. Neurologically, untreated hypothyroidism can cause peripheral neuropathy and cognitive decline. In children, congenital hypothyroidism without early treatment results in permanent intellectual disability and short stature. Chronic hypothyroidism can significantly impair quality of life and increase morbidity and mortality, emphasizing the need for timely intervention. Levothyroxine, synthetic thyroxine, T4, is the first-line and most widely used treatment for hypothyroidism. Its oral bioavailability and long half-life allow once-daily dosing, maintaining stable hormone levels. In adults, starting doses typically range from 1.6 micrograms per kilogram per day, but are lower in elderly patients or those with cardiac disease to avoid precipitating angina or arrhythmias. Dose adjustments are based on TSH levels, assessed 6 to 8 weeks after initiation or dose change, aiming to normalize TSH and relieve symptoms. Excessive dosing risks symptoms of hyperthyroidism, such as palpitations and osteoporosis. Liothyronine, synthetic T3, has a faster onset but shorter half-life and is generally reserved for short-term or special cases, such as myxedema coma or patients with impaired T4 to T3 conversion. Drug interactions significantly impact levothyroxine absorption and efficacy. Calcium, iron supplements, aluminum-containing antacids, and certain foods decrease absorption, so timing of administration should be separated. Understanding these nuances ensures safe and effective therapy, improving patient outcomes. Non-pharmacologic strategies are essential adjuncts to medication. Maintaining adequate dietary iodine intake is fundamental for thyroid hormone synthesis. However, excessive iodine intake can exacerbate hypothyroidism, especially in autoimmune thyroiditis. Patient education is critical, emphasizing adherence to levothyroxine therapy, recognizing signs of under or overtreatment, and avoiding substances that interfere with absorption. Lifestyle measures include managing cardiovascular risk factors, weight control, and psychological support for mood disturbances. In congenital hypothyroidism, early detection through neonatal screening programs allows prompt initiation of treatment, preventing intellectual disability. Regular follow-up is necessary to monitor therapy effectiveness and adjust doses. Supportive treatment of anemia or hyperlipidemia may be necessary. In some cases, consultation with endocrinology specialists enhances comprehensive care. Certain populations require special management considerations. Pregnancy increases levothyroxine requirements by 30 to 50% due to increased thyroid hormone-binding globulin, increased deiodination, and fetal needs. Untreated maternal hypothyroidism can cause miscarriage, preeclampsia, fetal growth restriction, and impaired neurodevelopment. Therefore, thyroid function tests should be closely monitored every 4 to 6 weeks during pregnancy. In children, early diagnosis and treatment prevent cretinism and growth failure. Patients on drugs like amiodarone, lithium, or immune checkpoint inhibitors must have regular thyroid function monitoring, as these agents can induce hypothyroidism via direct gland toxicity or immune modulation. Awareness of these nuances helps tailor management and anticipate complications. Additionally, elderly patients may present atypically and require cautious dosing. To summarize, hypothyroidism is a common endocrine disorder characterized by decreased thyroid hormone production or action, leading to systemic metabolic slowdown. Understanding the physiology of a thyroid and the hypothalamic pituitary thyroid axis allows us to interpret clinical features and diagnostic tests accurately. Hashimoto's thyroiditis is the most common cause in iodine-sufficient areas, while iodine deficiency remains significant globally. Clinical presentation varies widely, necessitating high clinical suspicion, especially for subtle or subclinical forms. Levothyroxine remains the cornerstone of treatment, requiring individualized dosing and monitoring. Non-pharmacologic measures and patient education enhance treatment effectiveness. Special populations such as pregnant women and children demand tailored management to prevent serious complications. Early diagnosis and consistent treatment prevent morbidity and improve quality of life. As future healthcare professionals, your role in timely recognition and management of hypothyroidism will be critical in optimizing patient care. For further detailed study, I recommend Harrison's Principles of Internal Medicine for Clinical Context, Katsung's Pharmacology for detailed drug mechanisms and dosing, and current guidelines from the American Thyroid Association. Review articles in endocrinology journals provide the latest evidence and controversies in management. Keeping abreast of new research is essential for practicing evidence-based medicine and pharmacy. Utilize trusted databases like PubMed and UpToDate for ongoing learning. Thank you for your attention throughout this comprehensive lecture. Feel free to share any uncertainties or clinical scenarios where you want further clarification on hypothyroidism diagnosis, management, or pharmacology. Also, don't forget to subscribe the channel for more educational videos.